Good afternoon, everybody. We are Team 2 from California North State College of Pharmacy, class of 2014. We're here today to talk about the proton pump inhibitors versus the gastroesophageal reflux disease. I'm Jackson. I'll be doing an introduction. Medea is going to talk about the cell and molecular biology. T-Lynn's going to talk about the drug targets. Doris and Christina are going to talk about drug class information, and Danny is going to summarize everything. GERD is gastroesophageal reflux disease. It is a condition in which mucosal damage is caused by acidic contents of the stomach refluxing upwards into the esophagus, causing heartburn and other symptoms. By the end of the presentation, you should understand the cellular and molecular biology of the PPI and GERD interaction, understand the different drug targets for the treatment of GERD, understand the MOA of PPIs, indications for the various disease states, side effects of PPIs, first and second generation PPIs, and interactions and contraindications, which will be part of additional drug class information.
Let's first talk about GERD. GERD stands for gastroesophageal reflux disease, and this is caused by mucosal damage produced by an abnormal reflux of stomach acid into the esophagus. This is due to transient or permanent changes in the barrier between the esophagus and the stomach. Heartburn can also be caused by incompetence of the lower esophageal sphincter and transient lower esophageal sphincter relaxation. GERD can also be caused by a condition known as hiatal hernias. This is a picture of a peptic ulcer. Peptic ulcers are seen in peptic ulcer disease, or PUD. They are painful sores or ulcers in the lining of the stomach and first part of the small intestine, known as the duodenum. There is also another disease state known as Zollinger-Ellison syndrome, ZES, and this is where one or more gastronoma tumors are found in the pancreas, duodenum, or both, and they release abnormal amounts of gastrin. This is caused by excessive acid production in the stomach, leading to peptic ulcers seen in the duodenum. These tumors are cancerous and can spread to other areas of the body. Talking about the molecular aspect of the disease, gastric acid is secreted by parietal cells of the stomach in response to different stimuli, such as the presence of food in the stomach or intestine, and also stimuli such as taste, smell, sight, or even the thought of food. Such stimuli result in the activation of histamine, acetylcholine, and gastrin receptors, namely the H2, M3, and CCK2 receptors. All these receptors are located in the basolateral membrane of the parietal cells. These receptors result in the initiation of a signal transduction pathway that converge on the final step, known as the activation of the hydrogen-potassium ATPase enzyme, and this is where you have the final step of acid secretion. This diagram shows the lining of the stomach where the stomach is lined with parietal cells, and these parietal cells are the ones that produce the hydrochloric acid. This diagram shows the histamine receptors, muscular receptors, and the acetylcholine receptors, where they can be activated through CAMP-dependent pathways and calcium-dependent pathways to ultimately activate the hydrogen-potassium ATPase enzyme, resulting in the increase of acid in the gastric lumen.
The drugs that we will be discussing today is antacids, H2RAs, antacid and H2RAs, and PPI, proton pump inhibitors. Antacid is used for mild to moderate infrequent symptoms of GERD. It has a rapid release and it neutralizes gastric acid in the LES, the lower esophageal sphincter. If the intragastric pH is maintained above 4, antacid can decrease the formation of pepsin from pepsinogen. Antacid increases LES pressure, and the neutralizing compounds are sodium bicarbonate, calcium carbonate, aluminum salts, and magnesium salts. H2RA is used for mild and frequent heartburn. It binds to histamine 2 receptors on gastric parietal cells to reduce the gastric acid secretion. For the combination of antacid and H2RAs is for intermittent or episodic GERD. It provides both the antacid speed and the H2RA sustained duration. For the proton pump inhibitor, it is for frequent heartburn. It has a slow onset but a long duration. It suppresses gastric acid secretion by specific inhibition of the HK ATPase enzyme system at the secretory surface of the gastric parietal cells. It blocks the final step of the gastric acid secretion.
So from this diagram, you realize that there are three different pathways that produces the acid in the stomach. There's the histamine pathway, there's the acetylcholine pathway, and there's the gastrin pathway. All these three different pathways end up with a proton pump, which is the final step for the acid to be secreted into the stomach. Omeprazole, which is Prilosec, lansoprazole, which is Prevacid, rabeprazole, which is Acifex, pantoprazole, which is Protonix, and esomeprazole, which is Nexium. All these are examples of proton pump inhibitors, and they all work by blocking the final step, which is the hydrogen potassium ATPase enzyme system, and then inhibits the secretory surface of the gastric parietal cells. This is another diagram showing the three different pathways that we just talked about, which is the histamine, acetylcholine, and the gastrin. And we see the HK-ATPase, which is the final step where the acid results from. And then the proton pump inhibits this final step. Omeprazole is used for gastric ulcers, erosive esophagitis, and GERD. It is also used for the triple therapy for H. pylori eradication. Lansoprazole is also used for duodenal ulcers, gastric ulcers, and for the treatment of Zollinger-Ellison syndrome. Rabeprazole is also used for duodenal ulcer, gastric ulcer, erosive esophagitis, and GERD. Pantoprazole and esomeprazole are also used for the treatment of esophagitis and GERD, and also for the triple therapy of pylori.
The common side effects associated with PPIs are the following: headache, diarrhea, abdominal pain, and nausea. The PPIs can be separated into two drug classes: first-generation PPIs, which are omeprazole, lansoprazole, pantoprazole, and second-generation PPIs, which are esomeprazole and rabeprazole. The first-generation PPIs have substantial interpatient variability and often interact with other drugs. A big disadvantage with these drugs are that they do not achieve rapid and sustained suppression of gastric acid. However, the second-generation PPIs are lower oxidative hepatic metabolism rate via the CYP2C19 enzyme. They have a lower metabolic clearance and greater inhibition of acid secretion. One of the more significant advantages of second-generation PPIs are they have a more rapid onset of action to provide reflux symptoms relief over 24 hours. Additionally, the four drugs interact with theophylline, ketoconazole, cyclosporine, clarithromycin, diazepam, and phenytoin in different ways by increasing or decreasing their plasma blood levels. Patients with known history of hypersensitivity or patients with severe hepatic disease and breastfeeding mothers should avoid taking PPIs unless necessary.
To summarize the presentation, gastroesophageal reflux disease is a condition in which mucosal damage is caused by acidic contents of the stomach refluxing upwards into the esophagus, causing heartburn and other symptoms. Drug types used to treat GERD include antacids, A2RAs, and PPIs. PPIs inhibit the hydrogen potassium ATPase, irreversibly blocking the final step in gastric acid secretion. The less acidic stomach contents do not have as serious of an effect on the inner lining of the esophagus. PPIs exist in two different generations that have different durations of onset, potentials for drug-drug interactions, as well as metabolic clearance. Common side effects include headache, diarrhea, abdominal pain, and nausea. Contraindications include patients with hypersensitivity to PPIs, severe hepatic disease, and breastfeeding mothers. PPIs are the first line of defense against GERD. I hope that you now have a better understanding for this disease and its potential drug targets. Thank you.